Good evening, everyone. I am Dr. Vaishnavi Pradhan from the team of Voice of Healthcare, and it's my pleasure to welcome you all to today's panel discussion on living with leukemia, supported by Pfizer. Leukemia remains one of the most pressing hematological cancers in India. Each year, more than 30,000 new cases are reported in our country, affecting both children and adults. It accounts for around 25 to 30% of all childhood cancers and continues to challenge patients, families, and our healthcare systems. While treatment have advanced, including chemotherapy, bone marrow transplant, and targeted therapies, patients still face significant hurdles, including infections during treatment, complications like tumor lysis syndrome, long term health effects, and need for continuous emotional and social support. Survivorships and follow up care are equally important, especially for young patients dealing with fertility concern, cognitive issues, and reintegration into daily life. With this backdrop, we have gathered a distinguished panel of experts who bring clinical, caregiving, and policy perspective to this important conversation. I welcome you all for the session. So we have Dr. Vinay Kumar Bohara, hematologist and bone marrow transplant physician at Vishesh Jupiter Hospital, Indore. Welcome to the session, sir. Then we have Dr. Dibyendu Day, consultant and head of Department of Hematology, Hemato Oncology, and bone marrow transplant at Balco Medical Center, Naya, Raipur, Chhattisgarh. Welcome to the session, sir. Dr. Priyanka Samal, Head of Department of Clinical Hematology and Stem Cell Transplantation at the Institute of Medical Sciences and SUM Hospital, Siksha O Anusandhan University, Bhubaneswar, Odisha. Welcome to the session, ma'am.
Thank you.
Dr. Madan Gopal, Advisor for Public Health Administration at NHRC. Welcome to the session, sir. So, thank you all for joining us. Let us dive into the discussion structured into key segments. So, my first question is to you, Dr. Vinay, that what precautions should pediatric or adult leukemia patient take to protect themselves from infections during the treatment?
Right. Dr. Vishali, thank you for bringing this out. So, the treatment which we give for, say, adult or pediatric patients with leukemia are usually chemo and immunotherapies. And because of those, their WBC platelet, all these counts would go down. When we talk about infections, it is all related to low WBC. So then there are some general and some specific advices. In general, we ask them to not to have raw food. It is always fresh, cooked home food, not having outside food. That is one. Avoiding salads and most of the times raw fruits. Second would be avoiding crowded places, especially when they are neutropenic, when their counts are low. And if it is very essential to go to some crowded place, then it is always with all the precautions which contact precautions which we were taking during COVID. So idea is to avoid exposure to outside world when their counts are very low. And of course, taking their antibiotics, antifungal, the drugs which we advise them on time, reporting their fevers to us timely. These are a few of many instructions which we give them during treatment.
Okay. Yeah, so that was pretty descriptive. So I'll take my next question to you, Dr. Dibyendu, that as per your experience, what are the most common infection risks in leukemia patient and how can we minimize them?
Yeah, so as Dr. Vinay has already described that during the treatment phase, these patients actually suffers from neutropenia period. So when the WBC counts is very low, their immunity power is very low, and they are very less chance to able to fight against the cancer. So at that point of time, they need to protect themselves so that the infection doesn't happen. And at that point of time, we give some of the medicines so that the infection doesn't happen, especially the antifungal therapy. That is very important when we give that, so that the fungal infection doesn't happen. Even some of the antiviral therapy or some of the antibiotic therapy like cortimoxazole therapy that is given to prevent the specific infections. As well as this time, these patients also have, sometimes they have a indwelling venous catheter. That means the type of catheters that is kept in these patients for the prolonged treatment. So these patients actually carry those catheters with them in the home also. So they need to take very useful or very deep care to these catheters so that the infection doesn't happen through those things. Again, the orifices, the mouth region, the anal region, these are the region which are exposed to outside infection. So these are the region where they need to take good care so that the infection doesn't happen in these patients. So these are the special instructions that should be kept in mind in these patients so that they can prevent this type of infections.
So, thank you for putting that up. So, my next question is to you, Dr. Priyanka, and it would be firstly that, I mean, if you can help us understand more that what are the common risks, and secondly, now since we have been speaking about the patients, how can caregivers also actively protect patients during chemotherapy to reduce these risks of infection that are there?
Yeah, thank you, Vaishali. So I would even add upon these are the things which Dr. Vinay and Dr. Dibyendu just alluded to. Apart from that, vaccination is something also which we ask the patient and the caregivers. So most of the time, we understand that vaccinations at this point of time, being hematological malignancies, their immune system is not that well enough to have a good amount of antibody titer in their body. But ideally, the antibody titer should be checked, booster if required to be given. Most of the time, our patients, we do not have those things. So we give the booster doses of hepatitis B because these are patients who require the blood products very frequently. And apart from that, now we have the Shingrix vaccine, which is, the one against the shingles. And if you look into our ALL patients, especially the kids, they are at a very high risk of having activation of the varicella infection. And that is also something, you will be a little bit of vaccination is important for them. Apart from that, the caregivers, as you just asked, the other persons who are staying with the patient, they also need to be vaccinated. But truly speaking, in India, I don't think we have given that much of importance to the caregivers. But yes, to the patients, definitely we are more concerned regarding the vaccination schedule prior as well as post their completion of the therapy.
Yeah, so thank you for bringing that up. That in India we are not concentrating much on the caregiver's standpoint. So I'll take my next question to you, Dr. Madan. That could you highlight any existing government or national program that support infection control or safe treatment environments for cancer patients, particularly?
Definitely, Vaishnavi. So this is a very pertinent question after hearing the previous speakers. Am I audible now? Yes,
Yes,
yes.
yes, you are. Yeah, very well.
So, so one of the important things recently for hospital prevention, we have issued lot of guidelines for the district and the sub-district level hospitals. NABH has also released a hospital prevention and control guideline. This talks about how the nosocomial infection which are there in the healthcare provider settings that have been taken care. But apart from that, we have to see that how the caregiver that the previous speaker was speaking about, caregiver is usually a neglected part. We have to see that how the caregiver is also being taken care. If you talk about the services which are being available, made available to this, one is having a protocols, having guidelines in positions how to avoid the infection. But the cancer related guidelines are still evolving because if you have seen that in the recent budget speech, daycare cancer centers have been sanctioned. In all the district hospitals now you would be finding daycare cancer hospitals in which all the protocols and other things would be there for addressing the infection related practices related to cancer patients and the caregivers. That's one. Besides that, I would like to highlight that few of the initiatives which the government is taking for addressing the issues related to this leukemia and leukemia related cancers. So one of the important things, we have a national program for prevention and control of cancer and cardiovascular disease, that NPCDS, that program was now, which is known as National Program for Non-Communicable Disease. which now operates in more than 700 districts and funds district level daycare chemotherapy centers. We have definitive guidelines of how these daycare cancer centers will run, how the patient will be taken care. That all the SOPs have been laid out if somebody is visiting the public institute. Guidelines are there, but the other challenge is how to implement these guidelines in the form of the capacities which are available at the district and the sub-district level, where we deal with volumes and volumes of the patient. That's another thing. Apart from that, other things which we are having is we are under the PM Abhin program. We are having an integrated public health laboratory network, which is improving the laboratory capacity for early infection detection and the antimicrobial resistance surveillance. You might have seen the antimicrobial resistance stewardship program. Some many of the medical colleges they are having this stewardship program where it's the infection control, early detection, identification of the causative organization is there. Besides that, another initiative which the government is taking for addressing this is free diagnostic initiative, FDSI we call it, which offers essential lab tests free of cost in the public facilities. Because if you talk about the cancer and the cancer related treatments, it's usually impact the pocket. uh, Pocket. That means it is very expensive. It is said that if a person is diagnosed as a cancer in a family, whole of the families for taking care of that expenses, it goes by 10 years. That's the kind of catastrophe which the cancer patients would be having. But to aid this catastrophe, to avoid this catastrophe, we do have PMJ Pradhan Mantri Jan Arogya Yojana, which covers hospitalization cost of up to 5 lakhs per family per year, which includes chemotherapy, blood products transfusion, and infection-related complications for the cancer patient. Besides that, apart from that, some of the states they are having the Rashtriya Arogya Nidhi and the state-specific CM relief funds, which provide additional financial assistance for high-cost medicines and hospital care for these vulnerable patients. Apart from that, the bottom line of all this thing is creating awareness with the help of NGOs. The government is having a awareness program where we call the Can Kid Cancer Kits, then the Yodhas, the cancer support programs, which are educating the families about the neutropenia precautions, hygiene, and vaccination during the treatment. That means overall, we are also putting in efforts. It cannot be a single person job that the government will take care of all these things. That's why we have broken in the NGOs and others for and labeling them as you have seen in the TV program also, Nishya Mitras. Here also we are pushing for CAN Kids, Yodhas, cancer support programs. And if you look at the building capacities around the daycare centers, many of the big cancer institutions, they are now acting as a hub for the district hospitals and they are providing services to the stroke. That means the guidelines and the SOPs which have been followed at the Apex Cancer Institution that have also been percolated to the district and the sub-district hospitals. And apart from that, if you look at the outcome of this kind of efforts, you see that the financial protection is being provided to all the patients because we are only focusing that how the financial protection can be avoided. Nevertheless, for the neutropenia related infections, we are very conscious of that. And whenever the patient comes to it, that standard protocols kicks in. So that's the efforts which we are making for handling this infection prevention for this. So this is a government and the national support which we are providing to the people.
So thank you so much, sir, for the descriptive answer about the public standpoint that where we are in terms of capacity building for protecting infection control and keeping a control and check on that. So going forward, tumor lysis syndrome, which is TLS, it is a serious complication that happens when cancer cells die rapidly and release toxins into the blood. So, highlighting that and taking up that conversation, my next question is to you, Dr. Vinay, that how do you monitor and prevent TLS in patients undergoing intensive therapy or bone marrow transplant?
Okay, so TLS is quite common in those patients who have high grade leukemias and lymphomas. So before starting treatment, there are some cancers where we expect that TLS might happen. Monitoring would be with some blood tests like electrolytes, which would include calcium, phosphorus, uric acid, and of course clinical parameters like urine output and other vital parameters. That is monitoring. But of course, there are ways to prevent it. Not that 100% of the times we would be able to prevent it, Once it happens, the treatment would depend on what parameters are deranged. If there are derangements of calcium, phosphorus, then it has to be replaced accordingly. If there are parameters like renal functions, if they are deranged, of course we will involve other colleagues, specialist colleagues like nephrologist, etc. But the treatment would depend on clinical manifestations.
Correct. So, thank you for explaining it to us. My next question is to you, Dr. Dibyendu, that how does early detection and rapid intervention for TLS improve the patient's outcomes?
Yes, so tumor lysis syndrome is one of the emergency in the cancer management because it happens at the very early phase of the treatment. Even sometimes in some leukemia, it can happen even before the start of the therapy. So it can happen because the large tumor burden is there, which is coming down because of the chemotherapy or because of the treatment. There is severe lysis of those syndrome, those cells, and that releases some toxins and that causes complications to the patients. So it's very important to first identify the patients who can have the tumor lysis and to prevent them so that and to be prepared beforehand so that we can prevent and we can manage these patients quite well. And for that we have few of the blood parameters, few of the indicators which provide us the indications that this patient may go to tumor lysis. Like we can do LDH, we can do the WBC counts, we can do the other parameters. And once it sets in, we can check with the repeated testing of the biomarkers, basically the biochemical parameters, the uric acid, potassium, calcium, phosphate, and we have to do it repeatedly, not the once, but repeatedly, probably every 6 hours, every 12 hours, to look for whether these patients are going into tumor lysis. And if it there, then we have to manage accordingly. We have to be prompt. We have to start the therapy very early, and we have to manage these patients in a ICU setting so that these parameters can be normalized with the electrolyte imbalance that is there. That can be managed quite well with the required supplementations. We may have to go for even nephroprotection. We may need dialysis in the initial part. And sometimes, most of the times, tumor lysis can be managed well if they are picked up early and they are managed properly. Then we can actually very well save these patients from the tumor lysis syndrome. So that's how we go about it.
Understood. My next question is to you, Dr. Priyanka, that what are the warning signs of TLS, and how should the families be aware and the caregiver should also be aware of this condition that might also happen?
Most of the time, actually, when the TLS happens, the patient, neither the patient nor the family members will be able to know it. So it is usually picked up clinically by the treating physician who is first looking at the child or to the patient. So there are two types of parameters, as we say, to define TLS. One is the clinical parameters and the other one is the lab parameter. So most of the time when a patient comes with a very high count, that is the TLC count. We are talking about leukemias with a very high TLC count, mostly with more than 50,000. So in that case, you will find that the patient will have some sort of a headache, blurring of vision. There will be altered sensorium. So these are something which will indicate that the tumor load burden is very high in the patient. And apart from that, there is a sudden decrease in the urine output. So these are neurological symptoms and the renal symptoms. These are the ones which are clinically actually mostly important for patients having a tumor lysis syndrome. And the lab parameters that we just mentioned, there may be, the first symptom is hyperphosphatemia, then comes the hypocalcemia, hyperkalemia. So since there is lysis of the cells, all of the parameters, uric acid level, they all increase. And urine output is something we have to monitor in these patients because hyperhydration is something which we like to put the patient on with a very with the fluid management being, it has to be very rigorous and vigorous, and at the same time you have to look into that the urine output is proper. Like in children, you have to look into per ml per kg per hour how much is the urine output. So adequately it has to be managed, and we require the help of dialysis at times and cardioprotection to be given so that the heart does not have a, most of the time these patients undergo a cardiac arrest because of the dyselectrolytemia which occurs in the tumor lysis syndrome. So this is something which is actually monitored by the physician rather than the caregivers, they will not be able to understand. Only in relapsed and refractory setting when they present again with a high count, but still it is very difficult on their part to understand. They will rather think that the low, the sudden decrease in the level of the consciousness might be because of the bleed in the brain rather than because of the tumor lysis syndrome.
Yeah, so very well highlighted on that point that there might be some misconceptions from a caregiver standpoint. So my next question is to you, Dr. Madan, that from a systems perspective, how can policies help improve access to rapid treatment and monitoring for TLS in India?
Vaishnavi, this very important question because I lost one of my dear person because of this tumor lysis syndrome. Because if you find that the tumor lysis syndrome is fatal within hours, if it is not promptly recognized, you see that when this is a very important oncological emergency, yet in our government system, only 30% of the district hospitals currently have standard emergency oncology protocols. Though we are working towards developing more oncology protocols, but right now only 30% of the list, that too the district hospitals which are working in a spoke model. Now you have asked about the policy level interaction which is there. The Indian Council of Medical Research is currently has issued a standard operating procedure for oncological emergencies. These have been adapted for the case cancer units, which we are doing it. These guidelines are available online, and you can always see them. Besides that, PMJ now reimburses the Pradhan Mantri Jan Arogya Yojana. That's insurance. That's the assurance scheme, the largest assurance scheme which covers more than 60 crore population. So that now reimburse high dependency units and ICU stays for cancer emergencies. That is ICU and SDU coverage is there. That includes dialysis and other procedures which are related to that. Besides that, under the National Program for Non-Communicable Disease, we have trained more than 2.5 lakh doctors, nurses, and paramedics for in early cancer detection. And now the states are adding a module of managing the cancer emergencies in that time. The National Cancer Grid, which we are having, is a real-time bed availability and referral system for the from to the tertiary sector that is already in operation. We are focusing on standardizing the tumor lysis syndrome protocols across all the empaneled hospitals, especially the district hospital, which would be a daycare cancer centers, so that we can fast track uh, and fast track diagnosis of this on a very prompt basis, so that treatment can be instituted and lives can be saved. Besides that, another thing which we are adding in the PMJS is the fast track approvals, so that the reimbursement of this life saving procedures can also be adopted.
So, yeah, thank you so much, sir, for helping us understand that where are we in terms of preventing TLS and such conditions from a public perspective and a policy perspective. So, a very important component in the journey of leukemia is supporting patients there during their long term treatments through nutrition, activity, and emotional care. So, taking that up, my next question is to you, Dr. Vinay, that how can patients maintain strength and overall health through good nutrition and safe physical activity during their long treatments?
Okay, so Dr. Vaishnavi, there is no one single answer to this because this is a very broad topic. In fact, it comes under the topic of supportive care. But the most important nutrients which are needed during the cancer care are proteins, some electrolytes, some amino acids. So we encourage patients to have home cooked nutritious food which would be high in proteins. We supplement them with formula feeds which are high in proteins, and then some amino acids, some unsaturated fatty acids. When it comes to some degree of physical activity, so that their muscles, joints, and everything is in place or in they are in order, uh, depending on the type of cancer they have, because there is no one single answer to this and there is no single blanket recommendation to each and everyone, depending on their age, depending on their mobility prior to cancer, depending on the type of cancer they have. They are advised some sort of physical activity, they are advised some sort of assisted physiotherapy, so that some degree of physical activity is maintained during the treatment. There are some patient support group, which will advise them. Then patients, they form a group, WhatsApp group amongst themselves, where they get advice on nutrition and physical activity.
Correct. So, thank you for helping us with the answer to the long term support that we can have for the patient in terms of nutrition and physical exercises. Diving deep into the same topic and taking this conversation forward, my next question is to you, Dr. Dibyendu, that based on your clinical practice and your clinical experience with patients now, that how important is emotional support and lifestyle management in improving the recovery and treatment outcomes?
Yes, obviously, not only the physical health, but the emotional and mental health is very important in this patient. First and foremost is this emotional health and mental health is determined by the well and proper information to the patient. Lots of time we see that, especially in India, that the patient's family members, they do not want to talk to the patient directly, do not want to inform the patient what has happened. But it has happened that most of the, because everyone is having Google in their own phone, so everyone tries to search what is happening to their life, and they get some information, true information, some misinformations, and that builds up in their mind, and that leads to a lot of confusion in these patients. So it's better to start with the proper dialogue with the patients himself as well as the family members, to give them proper information that yes, obviously cancer is there, but cancer is not the end of life. It can happen, it can have a lot of treatments, and with treatments it can improve. So it's a hope that should be given to these patients so that they can go on to fight with this cancer. And obviously these patients needs to calm down, needs to have a proper mental well-being is maintained, so that they can take their proper decisions and take the good and healthy lifestyles they can continue. That is very important. Sometimes we encourage them to take to talk with the psychologist, because we now have oncopsychologists. A lot of hospitals are now having oncopsychologists. They can help them in coping mechanisms, because these patients sometimes go into depressions in the initial part when they find the diagnosis. But it is the coping mechanisms that help them to overcome those initial shock, and then they can continue with their journey of treatments, because it's a long journey, long treatment for more than 4 to 6 months, and they have to continue this therapy in a proper way so that they can get the better outcome. So it's always there that they should not feel abandoned. They should feel that there are someone who is holding their hand during and throughout their treatment, so that they can continue and complete their treatment, and they can continue to again come back to the normal life after the treatment. So that is very important.
Yeah, so thank you so much for highlighting the importance of mental health in the long term journey of treatment for these patients. So my next question is to you, Dr. Priyanka, that how can nutrition, exercise, and mental health support help patients tolerate chemotherapy and long term cycles better?
Yeah, so putting it all together, I think like just the way Dr. Vinay started, that nutrition, protein diet is very important. And you understand, you know that in India, our diet is mostly carbohydrate. We have less amount of protein intake as such. And possibly as Sir just mentioned also earlier, we have guidelines. So for nutrition in oncology, setup is also very important. And there are guidelines, there are nutritionists too. What is the calorie requirement per day? How much is the child or the adult needs it per day? That has to be supplemented. Apart from that, I feel that many a times they have dysgeusia. We talk about nutrition, but possibly the child or the adult may not be able to take it at all. So in those cases, even if they take some amount of foods, like we allow kids to have, the preserved foods like chips at times when they are not at all willing to take, or they want to take some noodles. So this is something home cooked food that is completely allowed in the hospital also. There are particular dietitians to take care, so that each and every patient, according to the requirement, they are given the proper diet. At home also, we advise them to carry on with the home cooked food. Earlier he used to say that in the neutropenic diet we should avoid completely the raw fruits and vegetables. But apart from grapes, which has a lot of drug interactions, other thick-skinned fruits like the oranges, be it, or the watermelon, but it should be fresh enough. And even if they are taking some juice, it should be fresh, homely made. So these are something we need to think about. Having coconut water, that is very good for the electrolytes. You have severe potassium deficiency in these patients when they are having, the cells are recovering and you have hypokalemia. So these are something which needs to be taken care of. And regarding the emotional stability of the patient, the family needs to be educated as well as the patient needs to be educated. And apart from that, since we also deal with with a number of kids, we have a playroom inside our ward so that the kids are allowed some time to interact among themselves and give them a friendly environment. And some of the kids, they have, the bottles which are there. They have the stands which are mobile so that they can move around, or else even in patients who are having some, infusional therapy, which are going to be a 7-day course. So they have small infusion bottles which they can carry it along with them so that they are not confined to the bed most of the time. So these are some things, but definitely they bring about a change while you're managing the patient. Antibiotics, the patient does not need to be on antibiotics. We try to shorten the duration until and unless the patient is very sick so that he can be mobile and out of the bed for a longer amount of the time rather than being confined to the bed throughout and thinking that is a patient who needs to be stuck to the bed. So these are small approaches, but I think they bring about a impact in how you're managing talking to the patient in a sweet way rather than discouraging them, making them, feel that within some few days next they are going to be discharged. So that is what, boosts their energy at the and the mental strength that yes, they will be off from this hospital and they'll be discharged for a break to their home and then again come and continue with the chemotherapy. And another thing is like, there are sometimes our patients require, 6 months of hospital treatment. So daycare is something also very facilitating for them so that they can come, visit, take the chemotherapy injections on the daycare, and then be back home. When there are complications, yes, you need to educate them very well that they have to come and attend the hospital at the earliest before they enter into a febrile neutropenia. So first alarming sign that should be well explained to the caregivers so that they come and inform us and get admitted for the initiation of the therapy, whatever is required with the antibiotics and the supportive treatment.
Yeah, so thank you so much for explaining it to us in such details. So my next question is to you, Dr. Madan, that what policy measures can ensure access to wellness and lifestyle support programs for leukemia patients across India?
Vaishnavi, so as I mentioned about the district NCD clinics, and apart from the district health NCD clinics, if you look at the structure which the government has evolved over the last many years, we do have the peripheral most center, that is the health and wellness center, which is now called as Ayushman Arogya Mandir. We are having around 1.7 lakh functional Ayushman Arogya Mandir, where wellness is a component in that, where we talk about the nutrition, nutritional counseling, yoga, and psycho-oncological sessions are also being held wherever because palliative is a assured thing which we are guaranteeing it through the Ayushman Arogya Mandirs. That's one thing. Second thing, apart from that, we do have some mobile health initiatives, uh, like the e-Sanjeevani tele-oncology platform has delivered more than 200 million consultation nationwide. So cancer follow-up modules are also there, which have been added in this e-Sanjeevani platform. After the COVID, you have seen that how the teleconsultation, other things have revolutionized the care and the follow-up care which is having. Apart from that, we are trying to capitalize and tap the corporate social responsibility funds under Schedule 7 of the Companies Act, which are increasingly being channelized for to the patients, navigators, nutrition support, and transport for the rural families. Beside that, the PM Abhim program, which I have mentioned, is the largest infrastructure program, which talks about wellness rooms in district hospitals, where the allied health professionals, the dietitian, counselor, the physiotherapists, will support cancer patients along with the routine care. That's the thing which is happening. So it's not. I'm not claiming that it's happening as all the places, but this structure is there. Somewhere it would be implemented in the letter and spirit. Somewhere some lacunas would be there. But structures are there, and as the things evolve and the things mature, you'll be hearing more about how how they are able to provide services. We are also encouraging the states to earmark some of the funds, some of the this NP-NCD funds for supportive and palliative care to reduce the urban and the rural divide. We see that these are the initiatives which we are taking and that measures are already in place. The community health officers who man this health and wellness centers or the Ayushman Arogya Mandirs, they are trained to provide palliative care and the counseling, the support, the uh, counseling about the nutritional requirement, other things have been trained. But how far they are implementing it, so we have to only time will tell as the capacities and other things also evolve, and we will only know when things get mature.
So thank you, sir, for helping us understand that the framework is in place and we are still in the process of building capacity around the same. So that brings us to the concluding session for the day, where we will talk about life after treatment, which is survivorship, long-term health issues, and the access to follow-up care that is there for these patients. So for taking this conversation forward, my next question is to you, Dr. Vinay, that what long term health concerns, such as heart problems or cognitive effects, should leukemia survivors be aware of after intensive therapies?
Right. So long-term problems or long-term issues are usually related to the type of chemotherapy which is used during treatment. But for leukemias, there are some concerns: long-term cardiotoxicity, then neurocognitive defects, especially in pediatric patients, because there we give intrathecal chemotherapies, which may interfere with the development of brain, and sometimes they receive radiation to brain. That would also that may lead to neurocognitive impairment. Very rarely they may have secondary cancers because of chemotherapy. So that's why there are these set programs where once their chemotherapies are done, we don't tell patients that everything is the treatment is complete and you don't need further follow up. In these programs, they are called very frequently for two things. One is to keep a check on their cancer, whether it is coming back or not, and second is to monitor for long term side effects. So there are set protocols which we follow.
Yeah, so taking that conversation forward, my next question is to you, Dr. Dibyendu, that what strategies do you recommend to monitor and manage late complications like organ or heart damage post treatment?
So yes, so this is something very important, but probably not very much structured not managed in a very structured way in India, because probably there are very less hospitals where there are post treatment surveillance program is running. So, but it is very important, especially for the patients who are children who are having leukemia and post treatments. They are completely free of cancer, but they may have a lot of health issues during their growth and development. Most importantly, already been described about the neurocognitive defect that can develop in later in life, as well as the cardiac issues because of the chemotherapy and all. Other than that, they can have some lung issues because of the treatment. They can have endocrine issues, especially the thyroid disease or the diabetes that can develop early on in these patients because of the repeated exposure to steroids and other chemotherapy. There can be bone health, that means their growth and growth can be disturbed. There can be stunted growth in the fallout because of the long use of steroids in this group of patients. There can be difficulty, especially in adolescent and adult health, especially if the patients are undergoing bone marrow transplant. Then probably these patients may develop some defect in their sexual development as well as in the puberty and all. So all these things should be managed in a proper way, and for that we need a structured program in which we must follow up these patients every 3 months or every 6 months, and we need to do a set of tests and physical examinations regular basis, so that to identify these problems and to treat them accordingly in a proper manner at a very early stage, so that they do not lead to a late complications or a long-term complication. So that is most important, and for that I think not only the oncologist should be involved, but also the pediatrician, the adult adolescent health workers, and also the allied sciences like the endocrinologist, the bone health, the orthopedicians, they should also get involved in this multidisciplinary approach of the follow-up patients.
Yeah, so thank you for highlighting it so well regarding the multidisciplinary approach that is required for long-term survivorship of these patients. So my next question is to you, Dr. Priyanka, that what follow-up programs do you suggest for addressing fertility and cognitive issues in young survivors?
Yeah, so there are two groups. If you look into mostly it is for the adolescents as well as the children. So for the acute leukemia as such, we do not have as of now for the kids to have a preservation for the sperm or the oocyte preservation. But yes, for the adolescent females, we have this cryopreservation both for the oocyte as well as for the sperms. So in our practice, what we have found it is quite easy for the males to have the sperm donation and it is quite cheap. But for the females, the oocyte preservation, it is quite costly. It is around 5 lakh. And then our patients who have such less counts, the platelet counts are so less, to have an invasive procedure, again, it becomes difficult. So fertility as for these patients, what we have seen in our practice also, suppose in the females we are not able to cryopreserve the oocytes, but still after around 5 years or so, the fertility, they still have some chances of having children or getting a pregnancy. So that is one part or aspect to it. And regarding, as just Dr. Dibyendu alluded to, that the growth failure. Sometimes we find after the cranial irradiation, there is obesity in the kids. There is growth failure, early fusion of the metaphysis. So this is something the endocrinologist you have to talk to and you have to take care of it. But then every patient right from the outset, they have to be counseled that end of chemotherapy does not mean that it is an end to all the therapy to have a good quality of life. Secondary malignancies, they are also very important. Sometimes you will find within 2 years of completion of chemotherapy also patients will land up in having a second uh, be it a relapse or a secondary malignancy. These are something also we need to look into. So specific organs, cardiology, lungs, cataracts, early development of cataracts because the patients are exposed to very high steroids. So these are something we need to understand. Apart from that, antibiotics, some antibiotics or the analgesics with the patients use, they will have renal complications. So overall, whenever they come for a every 3 monthly follow up along with us. They have, we have some protocols which are the organs to be seen and how the echocardiography or else the cardiological investigations has to be done. So there is a defined protocol and it is very well mentioned among all the uh, the protocols which are made for the transplant or for the long term treatment like ALL. There is a very well defined vaccination as well as a schedule for the long term follow up. So that is what we have been maintaining in our OPDs. And this is also taken up very much care by the counselors that at which point of time what investigations have to be done and where the patient needs to be referred. So this is how we are doing as of now in our practice.
Yeah, so thank you for explaining it to us. My next question is to you, Dr. Madan, that how can national survivorship programs and policy address the long-term quality of life for leukemia survivors in India?
Vaishnavi, we have a draft concept under discussion at, with focus on fertility preservation, uh, then late effect screening, mental health, and return to work programs. We have this is work in progress. I can't say that how in which direction it will move. Besides that, the PMJ is also considering revising provisions to cover the fertility counseling and certain reconstructive procedures for the young survivors. These are all work in progress. Besides that, we are trying to see that how the patient reported outcome measures are built into the hospital dashboard so that we can at least get the patient feedback in the policy planning. That is also work in progress. Besides that, we are trying to rope in the groups like CanKids, Yodhas in co-designing survivorship care programs. These examples are seen where the good examples are from the state of Maharashtra, Tamil Nadu. We have already launched pilot for having that kind of survivor clinics. We're trying to see that how we can push for inclusion of cancer survivorship indicators in the health dynamic infrastructure. Every year we have been bringing out the previously the ministry was bringing out the rural health statistics. From last year, this was discontinued. Instead of that, it is the health dynamic infrastructure wherein all the statistics and other things are there. We are trying to bring in and push for inclusion of cancer survivors with indicators in this so that we can monitor the post-treatment outcomes at the facility level. Besides that, our vision for 2030, have we would be having a big nationwide network of survivorship clinics, which would be linked to health and wellness centers, ensuring no patient is lost to follow up after the remission. So this all from my side. I think I have to rush for some other thing. So the other statement, the concluding statement also I want to say that means we are building one of the largest public health safety net for these cancer patients in the world. Yet policies and programs must evolve from episodic treatment to life-saving care. We see that we are covering prevention of infection, timely emergency management, wellness with support, and survivorship. All can happen when all of us work together uh, and see that how we can help and help these cancer survivors to a productive life and a productive life cycle. Thanks here. I will log off after this. Thank you.
Yeah, so thank you. Thank you to all our esteemed panelists for sharing their valuable insights. And it was a great session and a great conversation with all of you. So thank you for taking out time and joining us. And we look forward for having more such discussions and having good outcomes out of it. So thank you. Thank you.
Yeah, thank you, Vaishnavi. Thank you.
Thank you. Good afternoon, everyone. I am Dr. Vaishnavi Pradhan from the team of Voice of Healthcare, and it's my pleasure to welcome you to today's discussion on living with leukemia, proudly supported by Pfizer. Leukemia remains one of the most pressing hematological cancers in India. Each year, over 30,000 new cases are reported across the country, affecting both children and adults. It accounts for approximately 25 to 30% of all childhood cancers and continues to pose significant challenge for patients, families, and our healthcare system. While treatment options have advanced, including chemotherapy, bone marrow transplant, and targeted therapies, patients still face considerable hurdles. These include infections during treatment, complications like tumor lysis syndrome, long term health effects, and the ongoing need for emotional and social support. With this backdrop, today's discussion takes on even great importance. We are privileged to have with us the speaker for this session, Dr. Amita Mahajan. Dr. Amita is a senior consultant in pediatric hematology and oncology at the Indraprastha Apollo Hospital, New Delhi. She also serves as chair of the medical advisory for Can Kids and as a medical advisor for Leukemia Crusaders, Thalassemia India, and the Foundation Against Thalassemia. Through her work, she has been a dedicated advocate for pediatric cancer care and patient support programs, bringing extensive expertise in managing childhood hematological disorder. We are honored to have you with us today, ma'am.
Thank you. Thank you for having me.
Thank you
And
so much
also
for joining.
thank you for, talking about childhood cancer to the listeners and viewers and to, spotlighting this, especially in the Childhood Cancer Awareness Month. September is celebrated globally as the Childhood Cancer Awareness Month. So our thanks to you for spotlighting leukemia in this month.
Thank you so much. So, and thank you so much for bringing to that to our notice as well. So, we'll quickly start with our session today and try and understand the infection prevention during the course of the treatment of this condition. So, what support systems helps patients stay safe from infection and treatment complication during the condition?
So, as you can understand, leukemia is a cancer of the bone marrow, which is where the infection fighting cells are produced and where they live. So, understandably, when we target leukemia cells, we further compromise their immunity and infection fighting capacity, making them vulnerable to infections. What's most important to understand is that the vast majority of infections that cause problems during leukemia are actually endogenous. That means that they come from the patient's own body. So our first and foremost request to them is to maintain excellent body hygiene, which means, a daily bath every day with special mouth hygiene measures using mouthwashes. Sometimes they're not able to brush their teeth, so mouthwashes, especially medicated mouthwashes, so that there is no bacterial overgrowth. We ask them to take special care of their genital area, which is, as you can understand, the back passage and the area where we pass the urine. That is the most contaminated area of the body. So infections can often begin there. So they need to just maintain very good hygiene. It is important that they also maintain good food hygiene, which may sometimes be difficult for families that have come from other states and are living in makeshift arrangements. They may have to get food from outside. So NGOs like CanKids go out of the way to make sure that they can have food cooked by themselves or kind of home cooked food, where best food hygiene practices have been maintained. It's also important to keep them away from very dusty environments and keep them away for where construction is ongoing. So where in the hospital we have leukemia patients, it's strictly prohibited to do any renovation work without taking additional precautions. We request families not to do any renovation work during the most intensive phase of the treatment. And if they are traveling, outside, and there is a lot of construction happening, they should use a face mask to protect them. So that is
Okay.
more or less what the most important thing is that all these measures may still not prevent infection. So it's just early recognition and prompt administration of, the effective antibiotics, for which all our patients carry a vial of antibiotics with them, so that as soon as they have fever or other signs of infection, after discussion with us, they can immediately take the first dose, maybe at a local clinic or a local practitioner, before they reach to our center or any the center that they are getting treated at.
So yes, thank you so much for explaining it to us that how can we prevent from infections since these patients are very vulnerable of picking up these infections. Now we also see tumor lysis syndrome, which is very strongly related to this condition, and sometimes it creates havocs during the course of treatment. So how can patient and family understand and cope with the risk of tumor lysis syndrome or many other complications like tumor lysis syndrome?
So, the tumor lysis syndrome we see in the most commonest type of leukemia in children, which is known as ALL. And it primarily results from if you have a very high tumor burden, or also it occurs in other diseases called non-Hodgkin lymphoma. These are the two category of diseases where we see tumor lysis, and like the word itself says, the tumor lysing very rapidly. So diseases where there is too much cancer burden, and they're very, very sensitive to treatment, so that even as the gentlest treatment is started, the cells just die or break down, and their toxic products are excreted through the kidney. So what we need to make sure is that the kidney doesn't get choked with these toxic products, for which they require fluids at maybe 3 times the rate that they would normally consume. Fortunately, this usually happens when they are hospitalized. So it is not for the parents, but for the doctors to make sure and take all the preventive measures, a high rate of fluid, ensure that they are passing urine regularly, check their blood parameters at frequent intervals, and this happens usually in the first 2 to 3 days. So, and we also give them some medicines to which can prevent tumor lysis syndrome in tablet form. But there is also a very effective injection called raspuricase. So patients who are deemed to be at very high risk of tumor lysis, they are given doses of raspuricase again in the first 2 to 3 days, and that can virtually eliminate the risk of tumor lysis syndrome.
Okay. So, ma'am, since you have been in contact with these patients for the longest duration of time now, I would also like to understand that what role do counseling or peer groups or lifestyle guidance play in helping these patients through their long-term treatments?
So I think in all of oncology, that probably plays the biggest role. We can give the treatment, prescribe the treatment, but it is counseling which makes the family understand the importance of treatment and continuing the treatment very religiously and rigorously. There are lots of hurdles in treatment. So, unless they get positive reinforcement, positive counseling all the time, it's very hard. A child getting cancer in a family is devastating for the whole family, and it's something that they were not prepared for mentally, psychologically, emotionally, and financially. So, there are so many hurdles. But luckily, there is a lot of support available from NGOs, from from government financially, and virtually all centers that work with children with cancer will be counseling centers.
Yeah, yes, ma'am.
Shall I
We
repeat
can.
that question?
Yes, I think we should start off
Okay.
where we left, which was, I mean, we were discussing about the role
Counseling.
of counseling and peer groups and lifestyle guidance.
Yeah.
So you can.
Yeah. So, as you can understand, when a child in a family is diagnosed with cancer, it is devastating for the entire family. And counseling plays such an important role in, first of all, bringing them to accept the diagnosis and begin with the treatment. Because for some families, it is so overwhelming that they may decide that they cannot really deal with this, and, maybe they will return back to their village or town because it is so overwhelming. That's where the counseling and peer support plays the biggest role. And luckily, most centers have social workers, they have patient navigators, they have patient peer support groups who have gone through the same journey, and they have been successful at the end of this journey. So, to hear from them, to hear from everybody the support that is available, I think it gives the strength and courage to the family to deal with this situation, begin the treatment, stay the path. Often there are setbacks during treatment, there are ups and downs, and then again the counseling becomes very important, but so that they do not turn back and go back again, but they stay the path, deal with these complications, and as the medical community, the social workers, the peer support groups, they all play a part in helping them. Fortunately, with us, the family system in India, the shared values, family values, they also give so much support to look after the other children at home, which we cannot help out with. And so that the family can actually focus on getting proper treatment for the affected child.
Okay. Yeah, thank you so much for highlighting that, ma'am. So now, since we are trying to navigate that how can they survive with the long-term treatment plan, etc. That also brings us to understand the survivorship of these patients. So, what advice can you give to the survivors about accessing long-term follow-up care and support services after the treatment ends?
So, I think this has been a learning or an evolutionary process for the medical community as well. Decades ago, when a child would get cured, we were so happy that this has been successful, that we were willing to pay any price for cure. Long term follow up studies have shown us that children, sometimes treated in the past, had very significant late effects. So, today, when we plan treatment for children with cancer, of course, the major focus is on curing the child, but there is equal emphasis that our survivors, they are not having to deal with significant late effects 20, 30, 40 years down the line. We assume that all our patients will be survivor. So the treatments are planned in such a way that we minimize late effects as much as possible. It's also important to make the parents and the child also realize that we have a relationship with them for life. because as they grow up, we will need to monitor them that they are growing well, they are entering teenage years normally. When it comes to marriage, are there any issues related to fertility? Most children will not have these issues, but they need to be on regular follow up so that the proportion that may have some problems, we can detect it early and we can manage it so that they can get over those things also uneventfully. All centers that treat children with cancer will have some form of survivorship clinic, some form of follow up. And now in COVID, we have learned how to use a virtual consultation. So it's not necessary that the patient needs to travel 500 kilometer, just for a visit. Virtual consult clinics have been set up, but we need to stay connected. Equally, as the children grow up into adults, they may want to know more about their disease. They may want to know if their children are likely to get that disease. They may want to know whether it is okay for them to marry, and what information can be should be shared with their partners. So for all these things, we tell them that this is a lifelong relationship, like in a family, and they need to stay connected with us. Uh, and that's how. And most parents and children are very willing for this. In fact, they enjoy coming back as a survivor, meeting with the old team that help them through this journey. And when they come, they also empower parents who may be beginning their journey. So they are the biggest, those who come back and who are doctors, engineers, lawyers now. Seeing them, a new family, can immediately feel positive that one day my child also will complete this journey successfully and will go on to fulfill all their hopes and aspirations.
Correct. I mean, it just makes me curious that I want to understand that how likely is it there that the offspring or the child of a patient might get this condition? Is it very likely, or how is it?
No, it is extremely, extremely unlikely. In fact, I think the children getting this disease is as the risk is the same as that for another child. There are only very few diseases like retinoblastoma, where one third do have a genetic form of disease, and that's why they need to be very necessarily be on follow up with us so that we can steer them in the right direction. It does not stop them from getting married, but we can detect it early, we can prevent it from happening, and just really guide them so that there is no reason why they can't marry or have children, but they need some extra supervision, and that can be easily provided to them.
So, thank you so much, ma'am, for taking out time and joining this session with us and sharing those valuable
Thank you.
insights.
Thank you
We
so
look
much for
forward
having.
of we yeah so we look forward for having you for many more sessions in the coming days, because this is a
Thank you.
topic which we should highlight and speak about, and let the information reach to the part where they cannot have the access to such informations. So thank you so
Thank you
much.
so much. And you have a big role to play about awareness. I'd just like to add one last thing, that childhood cancer has been identified as a global health priority by the World Health Organization. India has also pledged that we will strive to reach the goals set by the WHO. And the goals set are that by year 2030, every single child in India should have access to the best possible care. So I invite you and every viewer to join us in this effort. Let us all do our own bit, because these children deserve the best chance of cure medical advances can offer to them. So thank you so much for having me.
much. Thank you so much.